Synapsium's webinar series on holistic neurorehabilitation. So today we have Dr. Gaurish Kenkre speaking to us. He is a certified Bobath therapist. He's been trained in a lot of different countries, South Africa, Brazil, Australia, and he's been working for several years. He is currently the chief rehab consultant and heading the spine clinic at Leelavati and Breach Candy hospitals. He is also the director of the rehab team of India. He is the head of the physiotherapy department at Fortis. Clearly very, very highly qualified. And thank you so much, Dr. Kenkre, for speaking to us about physiotherapy and specifically, of course, neurophysiotherapy. To introduce the rest of the topic, we actually are going to continue speaking of very briefly what is neurorehabilitation, and then going into the specifics of physiotherapy and its collaboration with neuropsychological interventions, as well as neuropsychological interventions with physiotherapy. So what I mean is, how can neuropsych rehab add to physio, and how can physio add to neuropsych, keeping the holistic approach in mind. So, all right, before we proceed, I would like to hear from all of you about your backgrounds so that we can actually make this a little bit more fruitful for everyone here. Okay, I'm sorry, just give me a second. Okay, sorry about that. That was a bit of a malfunction. Can you all see my screen again? So we still have the answers coming in. So it looks like we have a very good mix of physiotherapists and psychologists here. Waiting for the rest of you to also answer. All right, so thank you everybody who's given in their answers. Looks like a clear mix of people. So I'm just very briefly going to introduce the topic. So we're here to talk about holistic neurorehabilitation. I will have used short forms and acronyms here and there. So just a quick introduction is going to be necessary. All right, so when we talk of holistic neurorehabilitation, we're talking about working with people who have had some sort of an acquired brain injury, whether that is a stroke, whether that is due to external impact or traumatic brain injury, which could be due to several different reasons, a sports injury or a road traffic accident caused injury. There are, yes, so there are several different reasons for a brain injury to have occurred. What happens after that will depend on the severity of the injury as well as um, the surrounding sort of functioning of the individual. So we look at the individual from a neurobiopsychosocial model in neurorehab. These are the various areas that are considered when we're actually talking about rehabilitating the individual. When we're talking about rehabilitating, we mean optimizing their current functioning. So, whether they're going to be lasting permanent deficits or not, despite that, how can we best um, make their functioning independent? The goals of rehab are usually increasing independence of the individual as much as possible. So, reducing reliance on surrounding situations or um, sort of the family member as well, and also trying to make the individual as productive a member of society as possible. So we look at the individual through the lens of cognition, emotion, physical independence, how easily they're able to communicate, behavior, and within the sociocultural lens. So a multidisciplinary team will include, of course, at the initial stages, the medical doctors. So if it's an open head injury, then a neurosurgeon will be required. If it is a stroke, then definitely a neurologist would most likely take precedence, depending on the cause of the stroke. A physiotherapist would be required if there are physical issues. A neuropsychologist would be involved for related issues. Speech and language pathologist, occupational therapist, apart from a whole host of other people. In some lucky cases, people could have access also to a physiatrist, but these are the main few who ideally should be involved. Now, what is the role of a neuropsychologist? Where does the neuropsychologist come in? Cognition, emotion, and behavioral functioning of the individual, which also has an impact on the psychosocial. So, when I say cognition, I'm talking about everything from being able to pay attention to having the ability to learn and recall information, what we call memory, problem solving, being oriented to their situation. Emotion would be whether there is post injury depression or anxiety, or, of course, in some cases, psychosis as well. Apart from that, emotional regulation. Behavioral functioning is going to be something that I'll speak about a little bit more in detail, and its impact on psychosocial. So I'm going to continue to actually discuss the different symptoms and the different outcome measures that a neuropsychologist can use. And at the end of it, I'm also going to talk about some of the interventions we use and how neuropsychology and physiotherapy can overlap. Okay, so now that I've explained the sort of role of a neuropsychologist to you and what areas we work in, I'm going to explain the maybe sort of the cascade of events. How should it flow? What is the operating procedure? So initially, there's an injury that would occur for the individual. After that would come the stabilization stage of things where the doctors are involved. And usually in India, passive physiotherapy begins practically in the ICU stage and then continues thereafter. Um, However, a neuropsychologist should most likely also be involved at the ICU stage, which doesn't often happen. But the first assessment needs to be a neuropsychological assessment, which focuses on the cognitive profile of the individual. When we begin the interventions, we begin with cognitive interventions. And over here, I'm assuming that the injury is moderate to severe in terms of the dysfunction level. There are different parameters that we use to classify the injury level. I'm not going to be getting into those details. I know that a lot of psychologists are here and they might not have a lot of details and a lot of educational sort of background in rehabilitation and specifically in neurological disorders. I definitely recommend looking at a couple of the past webinar videos. They're available actually on Synapsium's YouTube channel so that you can get the best understanding of what we're discussing here. So once the intervention actually begins, for a severe injury, we will see difficulties with insight and awareness. So we begin by building that awareness. Then there are cognitive interventions that follow. And once the individual has um, an adequate level of cognitive functioning, an emotion behavior assessment takes place based on which a psychotherapeutic intervention is planned. Now, this is all focusing on the individual. I haven't really added the psychosocial aspect over here, which is the individual's functioning within the paradigm of the family as well as society. All right, so when we're talking of a cognitive evaluation, this is one of the global cognitive screens that we end up using. As you can see, I'm hoping that it's actually clear for you, clear enough to see the subheadings. Those are the ones with the the gray background, the line. So we would very briefly assess a little bit of orientation, a little bit of attention and concentration, a little bit of short-term memory as well as anterograde and retrograde memory. We would look at various language functions, which I haven't shown over here. Also visuospatial processing, the ability to plan. And once we've looked at all of these, we get a sort of basic idea. It's a good starting point for us to decide in which areas we need to assess further for more details. We have a lot of different tests for specific functions after this. So, for example, the digit span test, which I'm not sure if y'all are aware of, but the instructions for that would be calling out certain digits. Calling out digits of different spans. So that would be 3 digits in one go or 4 digits in one go. And then the instructions, the individual, the patient has to actually call them out in the same order or then in the reverse order. Now, when they're calling them out in the same order, what we're assessing is immediate auditory attention. And when they have to reverse the order, it's assessing working memory. So when we're talking about this, immediate auditory attention is definitely going to be required for a whole lot of, if not all, the rest of the assessment that we need. So working with patients who've had auditory deficit as an outcome or as a consequence becomes quite difficult. Working memory will give us some idea of prefrontal and overall frontal functioning. We look at, so I have sort of added this basic infograph to show us what are the different areas that of functioning which are attributed to the specific lobes. So I've specifically focused on all of the neuropsychological functioning over here, some amount of overlap with speech, and some amount of overlap with occupational therapy as well. So when we're talking about frontal lobe functioning, this is another test that we use. It's called a trail making test, and this assesses focused attention. There is a second version of this, a second level of this, which is going to assess frontal lobe functioning as well, specifically set shifting and working memory. All right, so now when we're talking about the frontal lobe, right, as you can see, I have listed out certain cognitive functions, but there are a whole host of neurobehavioral symptoms. So when I talk about mood changes, so emotional lability, extreme emotional lability, changes in personality, emotional dysregulation, changes in social behavior, all of these. Now, if you take it back to the goal of rehab, the overall goal, usually the long-term goal that we're working towards, is making the individual a productive member of society and making them independent in their functioning within family and their overall social setting. For this, interpersonal relationships, of course, become extremely important. And neurobehavioral symptoms come in the way of it way more than neurocognitive symptoms. So this behavioral inventory, if you can look at the statements, will assess things from apathy to perseveration, which is constantly repeating or doing the same action. Apathy is a very clear withdrawal from relationships and from activities. Irritability, aggression, restlessness, also disinhibited, rude behavior, just being inappropriate socially. So these become at points very embarrassing for the family also to cope with. Now I'm going to just very quickly talk about temporal lobe functions. So over here, we're talking mostly about learning and memory and some language functions as well. So we have a test over here for memory, where we assess different stages of memory, the individual's ability to take in the information, which is registering the information, consolidating the information, recalling it, and also being able to actually recall after there have been interference trials as well. So this is just a sample of the score that an individual could get. The first column shows that out of what score. And the SD range, so the standard deviation range, becomes very important for us because this provides us a norm. So individuals of a particular age with a particular level of education, how should they be performing? What kind of a performance is considered acceptable? So what is average, what is above average, what is below average? These are the standard deviation ranges provide us with those normative data. The other thing, when I talked about the language skills, this is a test for, so it's a confrontational naming test. If individuals have word finding difficulties where they might be able to say that we wear this on our wrist, it it tells us the time, but they're not able to say wristwatch or watch, then that's a naming difficulty. Sometimes they're not even actually able to describe it. So basically the semantic information becomes difficult to access. Now, the parietal lobe, we are talking about dyscalculia or difficulty with visual attention. So we have here shown different tests for visual neglect, and I'm not going to get into the details of this. I just actually saw the time. All right, so visual neglect needs to be assessed, and of course interventions planned based on that. The occipital lobe has difficulties with different visual functions and perceptual difficulties. So over here, this is a test of naming once again, and people with perceptual difficulties might name things completely differently, not because of semantic information being unavailable, but because of perceptual difficulties. All right, so now as a neuropsychologist, how do we plan interventions? There are different types of interventions that we use. So there would be, for some functions, we will use a restorative approach, which is very specifically going to be cognitive rehabilitation. Now, whether those are functional, ecologically valid tasks, or whether they are paper pencil tasks, but how the function or how the intervention is actually carried out, with what level of intervention and with what level of scaffolding support. So now when I say scaffolding support, even if it is a simple paper pencil task, but teaching the individual strategies to improve their performance and being able to bridge that particular paper pencil activity to a regular everyday life activity is the only way that we're going to see transfer of learning into their daily functioning. Adding daily functioning activities is also very important. Creating a routine, helping the individual access information to their routine. So whether that would mean using a whiteboard to actually get their routine visually available to them and easily available to them, or teaching them to use a calendar, because at the core of it, disorientation tends to impact memory very significantly. Also creating fear and confusion. Um, Emotional support and psychotherapy is not just for the individual, but also for the family, and improving the family's intervention in the process. So, improving the family's participation after they've also had the chance to cope with it and understand the injury process. And wherever the restorative process of cognitive function is not possible, teaching them compensatory strategies and behavior modification strategies. These would be some of the different subtypes of interventions that a neuropsychologist would use to improve the individual's functioning. Now, there was something else that I had spoken of, which was building the awareness. And now, when I talk of awareness, the symptom that a neuropsychologist deals with is anosognosia. I know that there are many physiotherapists present here, and for some reason, the same term has a different meaning in physiotherapy. But in neuropsychology, the term means impaired self awareness. When I say impaired self awareness, very simply, it would translate into the individual just not being aware of the fact that they have had an injury in the first place. Now, as we can understand, if the individual is not aware of them having had an injury, they're not aware of the consequences of the injury, they're not aware of why they need therapy or rehab interventions, which would reduce motivation, which would reduce participation, and of course can lead to aggressive non-cooperation as well. Now, this has been one of the most important areas where neuropsychology and our interventions has helped physiotherapists and speech therapists. But and in the past, we've also actually done joint sessions. So between the physiotherapist on the team and the neuropsychologist on the team, we've actually designed tasks to help create better self-awareness and insight. This is a very, very long drawn process. It takes a lot of time for the individual to build this self-awareness, because the brain hasn't originally encoded the injury at all. So when there is no encoding of that injury, to be able to create the rest of the link of events becomes quite challenging. But once that has actually been done, then the individual's participation definitely tends to improve. And the other thing that we've noticed is the more high functioning the client is, the more difficult it is to get, the more pre-morbidly high functioning the client is, the more difficult it is to get them to participate when combined with impaired self-awareness. Um, sorry, it's stuck. Okay, so my screen is frozen. Sorry, is it changing for y'all, the slides? Can someone let me know? Really not sure. Okay, I only had a couple of more slides to go. The last one actually being the psychiatric outcomes of acquired brain injury. And here, what I wanted to talk about was the anxiety of not understanding what has happened to them, the depression based on the sudden change of functioning, the adjustment difficulties that an individual could have, um, also the psychiatric and the emotional outcomes for a family member become very important over here. Caregiver burden is something that we always have to deal with, because by definition an acquired brain injury is something that most likely has suddenly happened. So the family hasn't had the time to process their own emotions. They very quickly get involved with focusing and caring for their family member. So providing that emotional support to the family members, and at the same time optimizing their role in the individual's rehab, and looking into any other neuropsychiatric symptoms that the patient might have becomes very important. And I'll just give you a quick example of what these kinds of difficulties could be. I had a patient in the past, a 54-year-old lady, actually. She used to hear a voice. So she had an auditory hallucination post a stroke that she had, um, which constantly told her to jump out of her house window. She lived on the 8th floor of a building, and it, of course, became very difficult for her husband to deal with. However, what the concern over here was the emotional impact that it was having on her. Since this was a neurological cause, she was actually aware that this was a hallucination, but she could not yet stop it. So there was a lot of emotional sequelae that followed this. Is something, am I going crazy, or I'm getting scared, what if I actually do this? There were lots and lots of emotional issues that came up because of this one psychiatric symptom. So it becomes a very convoluted loop, and dealing with these symptoms is very important to ensure overall success of outcomes. So I'm hoping that I've been able to explain to you all the role of neuropsychology in sort of assisting physiotherapy outcomes, and the role of a neuropsychologist and a psychologist as part of the multidisciplinary rehab team. Just to summarize, the first thing is helping build the self-awareness, and also improving attention, as I had explained right in the beginning. There are times in severe brain injuries, even tracking and eye tracking and being able to attend to single word commands is difficult. And I'm sure that um, at least the physiotherapists in the audience who have worked with brain injury clients have faced this difficulty. So the cognitive difficulties like memory, attention, the ability to actually learn and carry over their learning from one session to the other, these deficits can be addressed by a neuropsychologist, which will improve the overall outcomes of also physiotherapy. So these would be some of the ways that neuropsychology can work along with physiotherapy. And I'm all right. Dr. Kenkre, if I can actually request you to please stop my sharing because I'm not able to. There's something wrong with, yeah.
Yeah.
Yeah, So the thing is, my screen is frozen and I'm not able to get out of the sharing mode. Thank you. Yes. Also, if I can just, yes, if I can just request everybody to please note down their questions, I will be able to answer them at the end.
Are you able to see my screen?
No, no.
Just 1 minute.
We still can't see your screen. Okay, now we can.
Yes. Thank you, Dr. Shraddha Shah, for giving such a wonderful presentation. In fact, I wanted to introduce you before your presentation, but you started. So
Oh, sorry.
just for the audience to know, Shraddha is one of the topmost practicing neuropsychologists in Mumbai. She is attached to Harkishan Reliance Hospital as well as Jaslok Hospital. So she is a consultant with them. She has completed her neuropsychology rehabilitation from New York, and we have in fact seen a lot of patients together and uh, as a team. So I have been in touch with her, and we have got very good response with our patients who have come through Shraddha. So thank you, Shraddha, for all those things. So I'm going to specifically today's topic. What I have done is because in a lot of physiotherapists there is not much of awareness about neuropsychology and when to refer patients for a neuropsychological assessment. And that's why what I have done is I've included more of combination of physical function and the cognitive task where the neuropsychologist comes into picture. And since we have worked together in that field, I'm sure this kind of specific reference to a neuropsychologist and working together really makes a difference for patients. So you should not just concentrate on the physical function. We have to take into account their cognitive behavior, which helps into physical function. That is something I wanted to specifically pass on the message of. So my today's objectives uh, for the today's presentation are examine the neuroplasticity and how this process in fact improves your brain injury recovery, and discuss the intervention options where we effectively incorporate cognitive and physical functional training. So that's very important, physical and cognitive functional training together. I always start with last things first. So the carryover message, what I want to give from today's session is, I wanted to इसको थोड़ा छोटा कर हाँ just 1 minute. I actually am not able to see my screen completely. That's why. Yeah. So my idea about today's session is cognitive needs of our patients with neurological problems. And to do that, what we normally have to do is we should focus on interprofessional education. That's very important. So what do I mean by interprofessional education? So face-to-face collaboration. So we should actually discuss our cases as well as all our educational things with each other. So in the multidisciplinary team, which is present in our rehabilitation. So we normally, when we come into the rehab scenario, it's the physiotherapist, occupational therapist, neuropsychologist, and the speech and language therapist. So they come into picture when we come into the OPD-based neuro rehab. So what I meant with interprofessional education is a cognitive therapist or a speech therapist should be able to slightly ambulate a patient using appropriate monitoring cues and techniques for gait and balance. Similarly, a PT or a OT can utilize high or low language load cognitive tasks based on the cognitive communication function of the patients. And also the occupational therapists can collaborate in all disciplines and help out the physios and the cognitive therapists to come out with a plan. So my topic about today is more of neuroplasticity and how does the neuroplasticity work when a person has an acquired brain injury. So neuroplasticity is what? So if you see that black dot in the CT scan, this black dot is never going to heal. So what we need to do is the surrounding area has to take over that function. But now, when does this surrounding area will take over the function? There are two important things to note. One is the demand given by this black dot has to be minimal, because if the demand is more, it will be too much on the surrounding area to take over the function. And the second point is the resources in this surrounding area should be such strong that they are able to carry over their own function and then take over this function coming from this black dot which is the injured part of the brain. So that's how neuroplasticity works. So neuroplasticity is taking over the function of that affected area of the brain, but that can be done only if we as clinicians support the brain by reducing the demand coming on that surrounding area, and we help the person to build up the resources in that surrounding area. So that's very important. So what is neuroplasticity? It is the ability to form new connections or reorganize the existing connections in the brain. Now we all know, now the research says that the neuroplasticity is a lifelong process, and all of us are learning, and learning helps in neuroplasticity. So neuroplasticity is experience dependent. That's very important. So there are two important things to know in neuroplasticity. The first thing is structural neuroplasticity, which is the changes seen in the CT scan or the MRI. So, as well as what is happening in the brain when we talk about neuroplasticity. So, changes in the strength between the synapses. So, as we build up those new connections, the synapses normally become more stronger. So, it's called as synaptogenesis. So, formation and fitting of a synapse into a new neural circuit. That's something which is happening at the structural level. Neural migration. So what happens is these neurons which are kind of absorbing the new circuits, they become specialized and they migrate to a new area which takes over that function. So these neurons get specialized and they carry over the new function which has been done. Now there is a new concept or new research on neurogenesis, which was always said that the brain cells don't regenerate. But there is a research where they say that there is some amount of neurogenesis which takes place in the brain. It's the creation of new neurons. And the neural death which can occur with aging or with an acquired brain injury. But what is more important is the functional neuroplasticity. So functional neuroplasticity is something what we manipulate at clinical level. So we as therapists, we as neuropsychologists, all of us like a speech therapist can kind of work at the functional neuroplasticity. So there are mainly two important things, learning and memory. So motor learning is something where we train the physical function, but there is also something which happens at the mental level or the cognitive level. So there is a lot of importance of attention, of memory of the person who is kind of retrieving that information which is given to him. So it's not only the physical function which the person should be trained in. It has to be kind of specifically we have to emphasize on clinical and memory issues normally. So attention, memory, all those things come into picture when we talk about neuroplasticity. So what does it do? It does play a role into permanent synaptic changes. So when you work in a clinic, it is a temporary change what we organize. When we repeat those things in a clinic and when we take it to the outside environment, what we end up doing is a permanent synaptic changes and a permanent pattern, which is a new pattern for the person who is learning. So what happens when a person undergoes a traumatic brain injury? Normally there is a lot of diffuse axonal injury which happens. So there is an axonal stretching and tearing, changes in the electrophysiological function, distribution of injury may be multifocal or uneven, and that's why there is a strong drop in connections between the whole brain and the periphery. So we need to kind of reform these connections involving the cognition and the physical function. That's very important. So when a person goes through a traumatic brain injury, the primary cognitive disturbance is the disruption of something called as power function. So what happens when you have a disruption of power function? Your basic capacity to function in any cognitive task is affected. If you see a lot of head injury patients or a lot of patients in the early stages because of, so if you ask me about a stroke patient, because of so much of medications, their arousal level is less. They have a reduced channel capacity. So because of this, their processing speed is altered, and that normally kind of uh, when their processing speed is altered, their multitasking abilities are affected. And nowadays, when we work as a therapist, we are doing a lot of things with dual tasking or multitasking. So in our therapy, we include a lot of dual tasking methods. And that is where a cognitive therapist comes into picture. Because when you are involving a patient into a dual task, they have to have a proper attention. They have to have their memory system alert. So those things are very important. And in these patients, normally there is a reduced cognitive endurance, and that is why working as a team is very important. So disrupted power function manifests clinically as impairment in attention and memory. With further recovery or less severe injury, if you see some patients, when they are in a closed environment, they can concentrate better. But when they come into an outside environment or crowded environment, or when they are distracted, they are not able to concentrate. So this is when again we take opinions from a neuropsychologist. They tell us that you work one-on-one with this patient, we try and do that, and then slowly take them into the outside environment and add small disturbances in their function, and then see how they are able to cope up with those tasks. So somewhat preserved fund of information is likely due to less impact on posterior brain structures, because these posterior brain structures carry something called as your long-term memory or the procedural memory. So these are memories which work at the subconscious level. So subconscious level is something which is stored in the brain. So what you need to do as a therapist is you just need to tap into it and reactivate it. So that's why most of the brain injuries, it's normally on the frontal or parietal lobes. They cope up and come together very well if the posterior structures are spared, because we can tap into that procedural memory which is intact. So there are some specific types of attention, because it's more about teamwork involving neuropsychologists. I have kind of taken this into my presentation. So different types of attentions are focused attention, sustained attention, selective attention. So focused attention is when you respond to discrete visual, auditory, or tactile stimulus, something like someone calling you and you are turning your head to that stimuli. Sustained attention is how much time you can concentrate on one thing. Selective attention is you are able to selectively kind of ignore the irrelevant distractions coming into the system. Alternating attention, it gives us the capacity of our mental flexibility. And divided attention, so ability to respond to multiple simultaneous tasks. So these normally can be measured by the outcome measures which Dr. Shraddha spoke about, and that's why those outcome tests are very important, so that we know what we can use in our training. Now, coming back to neuro rehab, what are the keys to successful neuro rehab? So, as all of us know, that it is not the muscles or the joints which are directly affected. So, there is nothing wrong in the muscles or nothing wrong in the joints. It's the connections coming from the brains which are affected. So, initial stages, the only way to communicate with the brain is by using something called as a sensory stimulus coming from your proprioceptors. So there are mainly 4 sensory receptors what we make use of. They are your mechanoreceptors, your Golgi tendon organ, your muscle spindle, and your joint receptors. So how to stimulate these? So normally if I want to stimulate my mechanoreceptors, you just do a small wrinkling around the skin. If you want to stimulate your Golgi tendon organ, you have to use vibrations. Muscle spindle responds to stretch, and joint receptors respond to compression. So what what they do is, I will just show you. So when you activate the sensory receptors, they send a afferent impulse to the cerebellum. So all the information goes to cerebellum, the sensory information. So cerebellum sends one small impulse to the cortical structure, but it sends the main information to thalamus, which screens the information. So thalamus is called as the gatekeeper, and then after screening, it sends an impulse to the cortical structures again. At the same time, the thalamus also sends a small impulse to the body schema. So body schema is the internal representation of your action plan. So every time you work and you do an activity, there is a impulse which goes to the body schema, and the body schema resolves. So there is an increase in the resolution in the pixels of body schema, which builds up the strength of body schema. So the activity becomes more easier as you repeat it. The body schema also sends a small message to the cortical structure. From the cortical structure, message is given to the basal ganglia, and then the basal ganglia assesses if the plan is good, it gives a go ahead, and the plan is carried out by the efferent pathway. If the plan is bad, then the basal ganglia says a no. Coming back, so this was the efferent pathway which takes the message, and efferent pathways are the descending tracks which come down. So normally in our therapy, we cannot directly communicate with the descending tracks in the initial part of rehab because the patients are completely flaccid and they have no tone. But what we can do is we should know the function of these descending tracks, which track does what. Like a tectospinal tract coming around the neck is mainly responsible for your neck extension. So what, as well as stabilizing the gaze. So if you just put the patient's neck into extension, you may end up activating that tectospinal tract. Similarly, a vestibulospinal tract has two ends, medial and lateral. So medial is again responsible for your gaze and the neck stability. The lateral one goes down to the limbs, which gives an extensor activity in the limbs. So if you activate the extensor activity in the limb, lower limbs, if you put the lower limb into extension, you may end up activating the lateral vestibulospinal tract. Similarly, reticular activations are responsible for thoracic extensions. So they give commands to the thoracic extension. You put the patient into thoracic extension, you can activate the reticular activation system. A propriospinal system. Propriospinal systems are coming like projections from the spinal cord. From the spinal cord, they are projecting into your spine. So they have something called as long propriospinal system and short. The short one projects only at 2 levels in the spine. The longer one projects more than 6 levels. So kind of activating the multifidus, just giving a small stimulus around your spine can activate the propriospinal system. So this is how you can kind of communicate with the brain in the initial stages by giving the rehab. But again, in all these things, the patient's cognition is very important. Patient's attention is very important. Patient's cooperation with you is very important. So these things are very important in your rehab. Next thing is minimizing the demands coming on that limb which you are training. So if this is the affected limb, to minimize the demand, what you will have to do is you will have to offer support to that limb. You will have to reduce the friction coming from the supporting area. So you may have to add a towel or maybe a skateboard. You will have to kind of use some equipments like a functional electrical stimulator, which can help you in the functional activity by giving a small muscle contraction. So this is how you minimize the demands coming on the limb. But you can also make use of the resources. As I was talking about, the surrounding area resource needs to be strong, then only it can take over the function. And these resources are patient resources and therapist resources. So patient resources is something which is coming from within the body. So it can be patient's vision, patient's cognition, patient's attention, patient's auditory system, hearing capacity, how he responds to the verbal cues, as well as the resources coming from the therapist. So what equipments does the therapist have for this patient? What knowledge or skills does the patient have for his treatment? So it's not that all the therapists are kind of trained in all the concepts. So they can use their own skills for specific use of resources. So this is the main key, how you go about with a successful neuro rehab. So stimulate or activate the neural drive by using your afferent and efferent systems. You minimize the demand of the limb which you are training, or the trunk, or the lower limbs, and make use of the resources which are within the patient and which can be given by the therapist. There is another important thing which I wanted to talk about was there are some other receptors which are present in your trunk or the viscera in your abdomen called as gravireceptors. So you should make use of these receptors also when you're training the patient, because gravireceptors normally help you to orient yourself to vertical. And how do you normally train these or activate these gravireceptors is by increasing the intra-abdominal pressure, or by working on the core muscles, or by working on the trunk. So that's why in the initial stages also breathing is given so much of importance. Why does breathing play so much of role in neuro rehab? Because that helps in increasing the intra-abdominal pressure. So diaphragmatic breathing is something what we emphasize in the initial stages, because that helps to activate the gravireceptors. And these are the sensory receptors which can communicate with the brain in the initial stages. So how do we do an assessment? So normally when a patient comes to you, you either ask the patient or the patient's caregiver that what activities did the patient participate before the episode of brain injury or before the episode of stroke. So for example, if the patient is a student, so what activities normally a student has to do? He has to normally do studies. So whether he is able to participate in his studies now or no. If he is not able to participate, that will come under his participation restriction. Now, why is the person not able to participate in his studies? What activities do you need when you are studying? You need to sit near a table. You need to, so you should be able to sit. So sitting is an activity. You should be able to write. You should be able to read. All those activities, whether the patient is able to do those now or no. So there is a physical component and there is a cognitive component. So why is that person not able to do these activities? Why is he not able to sit? Because lack of trunk control, less tone in the trunk. Why is he not able to read? Maybe there is some perceptual problem. There is an attention deficit. Whether he is able to recollect what he is reading. Is there a memory deficit? Whether he is able to write. Is there something which is blocking him from writing? So is there weakness, pain, tightness in the musculoskeletal system? All these things come into their underlying impairment. And when we are treating the patient, what we do is we go the reverse way. We target the underlying impairments, like we work on their attention deficits, we work on their cognition, we work on their weaknesses, we work on their tightnesses, and we kind of target those things. We try and train those things so that the person is able to do those activities, and so that the person is able to participate in his function. So this is how I normally do the ICF clinical reasoning. So if cognition was a problem, then it comes into impairment. But if the person was good cognitively, it will come as your resource. So it will come under your function and structure. If the person was able to sit, it will come into your activity. If he was not able to sit, it will come under the activity limitation. Vision. If person is able to see, it will come under function and structure. And if he was not able to see, it will come under the impairments. So why I am talking about these four columns is impairments and activity limitations are your problem areas. But at the same time, activities and function and structure are your resources. So you don't just treat the problem areas when you are treating the patient. You have to also make sure that you make use of these resources. You need to make use of that sitting, what he is able to do. You need to make use of that vision, what he has, or cognition, what he has in your training. So these two columns are for resources which we are using, and these two columns are for impairments, what we are targeting. So most important part of having an association with a neuropsychologist and physiotherapist is when we train the patients in dual tasking. Now, what is dual tasking? So the dual tasking is a performance of two tasks simultaneously. So it can be two physical tasks, it can be two cognitive tasks, or it can be a combination of one physical and one cognitive. Two or more tasks also can be taken into picture once you want to make the activity more complex. So two physical tasks can be moving the lower limb and upper limb together. That can come into a two physical tasks. Two plus cognitive task may be, with one hand you are kind of catching one ball and with the other hand you are kind of pouring water in another glass. So it can be combination of two cognitive activities at the same time. Combination of cognitive and physical activity can be, you are putting a ball into basket. So cognitively you have to put it into a basket. So that is a cognitive demand, and physically you have to kind of have that strength to put the ball into the basket. So that's a combination of cognitive and physical activity at the same time. So why is dual tasking so important? Because the current research is completely supporting dual tasking. It is looking at the combination of a physical activity and cognitive activity, and at most these interventions are helping the patient to kind of go into function early. What it does is the physical exercise and the cognitive exercise can increase the secretion of a neurotropic factor called as BDNF, which is associated with improving the mental function. So it helps into your alertness, it helps into your cognition, and it helps into kind of building up the memory of the task what you're training. So that's why kind of involving the patient into dual tasking is very, very important. So now there is very important research which is going on. What they say is when you're training a physical function, the surrounding areas are taking over. So when the new pathways are building, that area which is affected is bypassed. And when you're training a language and cognitive function, what happens is there are some new circuits which are built up in that affected area. So there is some difference while training the language and cognition and while training the physical activity. But this research is still in progress, and there are a lot of papers available which you can go and read through the on the internet. It's called as neural prioritization. Prioritization. Same network is activated not only when we execute the movement but also when we think about it. So that is something called as mental practice. Mental practice is again into research, mental practice or imagery. So what they say is it's not the physical task what you perform. You can just kind of imagine a task which you have. So it's very important when you practice or do a mental practice, there has to be some amount of motor function which has to be present. So if there is some amount of motor function, you can use the mental practice for training that particular task. So you just imagine the task without performing it physically. That's how you can actually train the physical task. So mental practice or mental imagery is also into research. So kind of combining your activity, standing or sitting. While standing or sitting, you can perform something like swallowing or gesturing. So what it does is it kind of involves the patient into your activity. It increases the arousal, it increases the meaningfulness of that activity for that person whom you are training. So you have to take advantages of these automatic processes which are there. So swallowing is normally an automatic response. So when you are swallowing and getting up, you are using that automatic response and sending that activation message to the brain. Some of the functional activities in dual tasking can be driving, cooking, laundry, personal hygiene, medication management, which you can give it to your patients, dressing, eating, money management, typing, texting, etc., etc. So a lot of things can be used in dual tasking. Yeah. quickly I'll go through my concept training. I'm trained in Bobath concept. So because there are a lot of neuropsychologists there, so I'll just quickly go through something called as Bobath concept in 5 minutes. So this is my training which has happened in Bobath concept. So what is Bobath concept? If you see these two gentlemen trying to shake hands with each other, they won't be able to shake hands unless they do balance on that edge where they are standing. So postural control is something which is very important when you're training an individual with Bobath concept. And that's why it's defined as problem solving approach to the assessment and treatment of individuals with disturbance of function, movement, and postural control due to the lesions of CNS. So there is no fixed exercise. It depends on what function the patient needs to do. You train them accordingly. So Bobath concept normally uses normal movements. So normal movements is something when we are eating, we always eat like this. You go to your mouth. When you're combing hair, you always comb reaching your hair. So the activities are specifically defined. Eating activity is always bending your elbow and coming close to your mouth. Combing hair is an activity where you go out, you do an external rotation and comb your hair. So normal movement is considered as a skill which is acquired through learning for the purpose of achieving the most efficient and economical movement or performance of a task which is specific to an individual. So what happens is, if I say eating, most of us eat in a similar manner. There are some small variations, like while walking, if you see, some people walk straight, some people walk with external rotation. So that's why that normal movement is also called as typical movement, because typical movement, when you call it a typical movement, it gives some range of variations to that particular activity. So if I ask somebody to shake hands with me, what happens is you always have the distal part moving first and then the proximal follows. So in a normal movement, the body segments are in alignment throughout. The degrees of freedom are controlled. What that means is when I shake hands with somebody, I don't have to kind of go out and come ahead. It's an automatic response of coming ahead. But in my shoulder, there are a lot of degrees of freedom. There is abduction, there is flexion, there is extension. But when I have to shake hands, I'm controlling that degree of freedom. I'm not going into abduction, I'm just coming into flexion. So that's how that degree of freedom, which is controlled, is automatic. But in patients, if you see, if you ask them to shake hands, they will go outside, the hand moves outside and then comes ahead. So they don't have that control over the degree of freedom. And when you are training them, you have to make sure you are also training them to control the degree of freedom in which they are moving. So we focus on two kinds of tone impairments. One is less tone, which is called as placidity, and more tone, which is called as spasticity. So when the tone is less, we give them exercises to increase the tone. When the tone is more, we give them exercises to reduce the tone. So these exercises are called as tone influencing patterns, and these are the movements which regulate or normalize the postural tone, at the same time elicit a functional active movement. Last thing, there are 4 key points of control what we used in training. Thorax, which is called as the central key point, your shoulder, which is called as the proximal key point. For the lower limb, your pelvis and your hips are called as proximal key points. In the upper limb, wrist and hand are the distal key points. In your lower limb, your feet and your ankle is the distal key point. Why we need to know about the key points is we use these key points for facilitation. So facilitation is we kind of recreate that normal movement while facilitating. So we need to know how do your key points move in relation to each other when you are doing a normal movement. So how a distal key point moves in relation to the proximal and the central key point, and how a proximal key point moves in relation to the central key point. And what we normally do in facilitation is we recreate this ability of the patient to move their key points in a normal manner. In our key point facilitation, we facilitate the movement as a whole, or you facilitate the muscles which are responsible for that movement. And lastly, when you facilitate, you have to make sure that you are not passively pushing the patient into that movement, but rather you are kind of guiding and waiting for that automatic response to take place. Yes.
Thank you so much for that. That was very, very comprehensive, extremely useful. There was a lot that I learned from it. I can't hear you.
Yes. Thank you, Shraddha.
Right.
Thanks.
So I think one of the main takeaways that I had as a psychologist, I definitely really liked the information that you gave about the dual tasking. That I think that is definitely something that we've been doing, the joint sessions, which I'd mentioned. And I think the other main takeaway was that even if the client is I think hemiplegic or quadriplegic, getting them on a tilt table and getting them in a vertical position to activate the reticular activating system. I think that is also very useful for the cognitive tasks. So at least in our sessions, we can do that so that they can be more attentive
Right.
and encode more information. Would you suggest that?
Of course, yes. So
Right.
taking them into vertical, in fact, activates the arousal level also. So absolutely,
Right.
we normally try and do that in our therapy. So as soon as possible, we try and make them vertical, either into sitting or standing. So that's
Yeah. And
what
I
we.
think the key thing that you said right now is at least in our sessions we do it. And that exactly is the point, right? I mean, interdisciplinary sessions would mean that being able to actually use the same kind of strategies.
Start that specific cognitive rehab in the early stages of our
Yes,
therapy. That's very important. And I have
true.
seen that helping in our patients. So that's why I was
Yes.
insisting and emphasizing on it.
Absolutely. Yeah. And I think you did a very good job of doing that. And I'm sure a lot of the young physiotherapists who are
I
listening
gave
in.
my PPT around 10 a.m. in the morning. This because it
Oh,
was
wow.
rehab. so, I,
Oh,
so
okay. Yeah, and I think, I mean, when you talk about BDNF secretions increasing, which of course we know lead to neurogenesis also. So I think the dual tasking, I think, is definitely the way forward. And just a couple of tasks, maybe if I can add, doing cognitive exercises, not just cognitive tasks, while doing physical tasks would be helpful. So when I say that, what I mean is, let's say if they're doing arm raises or lifting the leg, once they've progressed a certain level, getting them to do certain calculations or getting them to say a particular word, spell it backwards. So adding a working memory exercise or adding a verbal activity, that's something which at an advanced level could be helpful. So yeah, thank you very much. We can now, I think, go on to take some questions.
yeah,
So maybe if everybody can just type their questions in the chat, then that might be easier rather than unmuting everyone. So, all right. So there's one which says, how is dual task similar or different from multitasking in normal life?
yeah. So dual tasking is something. So when you are training a patient, you should not kind of take too many things together because that's too much of demand on their physical as well as cognitive abilities. So that's why initially when we are training, we normally do dual tasking and then gradually take them out in the environment with multitasking. But whatever activities or functions we normally do in our daily life or function in our daily function is always a dual task or a multitask. We don't do a single thing. So even if you're walking for something. So there is a stimulus why we are walking. But whenever you're training, always focus on less activities. Don't take multiple tasks together.
Avoid the
Don't make it
cognitive
too complex.
overload.
Yeah. Don't make it too complex for the patient. You can add, Shraddha.
Yeah, no, I completely agree with that. Just that in rehab, we try to focus on any one singular function. So, in fact, breaking it down to that one singular function can sometimes be the challenge. But I agree with what you said. I think the
Yeah.
next question is, if a patient is affected 10 years back, is it possible to get to normal walking or hand movements?
So what happens is, first answer is, it's not that it's impossible. It is definitely possible, but there is something called as dynamic action theory. It works on something called as unlearning. So when you learn something, either the right way or the wrong way, the person is always learning. And there is something called as a deep well and a shallow well in dynamic actions theory, which is given. So when I keep a ball over a shallow well, we can easily move a ball. But if the well is deep and there is a ball inside, it's very difficult to move that ball. So when a person learns to do something a wrong way, he's still learning. The brain is still learning, and as it's learning, the ball is going into that deep well. And then to unlearn that, it's very difficult, because moving that ball from that deep well is difficult. But yes, if you do some repetitive practice of that particular normal movement, what you need to do, which the patient has not done over those 10 years, then definitely it is
We
possible.
lost your voice.
Yeah, so now can't hear? 1 minute. Yes. Can you hear me?
No sound. Wait, can the rest of you hear him? Oh, sorry. So then it's me. Please
Okay.
go ahead.
So coming to that 10-year thing, so if you do a new movement which the person has not done over the last 10 years, then you can still retrain those movements, but the repetition plays a key role in that. So you have to make sure that the repetitions of those new movements are more than those abnormal movements which are happening in his body. That's very important. Okay. Yes, this is for no? So
There's what?
Shraddha, there is
Yeah,
a
now I'm back.
question for you.
Okay. How can
Yes.
agnosia,
How can
like,
agnosia, like not recognizing faces or places, or one's own body parts, can be?
right? So each of these, of course, is it's a different symptom caused by lesions to different parts of the brain. So if I'm talking about the agnosia, yes, if I'm talking about prosopagnosia, which is the difficulty to recognize faces, then there's very rare cases of developmental prosopagnosia. So I'm going to go with the acquired symptom. Now, when we're talking about the difficulty to recognize faces, what we need to do is use compensatory strategies. This is not a function that can actually be restored. So a compensatory strategy, an example would be that when a family member comes in, let's say at the start of a day when you're wearing fresh clothes, when you've had a change of clothes, you need to speak first, because the sound is still recognized, the sound of your voice is still recognized, and of course introduce yourself. So when that happens, then the recognition of the face is not what you're relying on. In very extreme cases, there have been a couple of case reports where individuals have not been able to recognize their own face as well. And then, of course, dealing with a lot of the emotional sequelae becomes very important in this situation. However, restoring the function is not an option over here. The other thing that we can do, so when you say not recognizing places, that's not an agnosia, that's actually more disorientation and possibly a memory function that we're talking about. So that will definitely have different interventions. So if there's disorientation to place, so let's say I look out of my window and I say I'm in New York, then it will need to be more visual inputs, constantly sort of telling them. So that whiteboard strategy that I mentioned, it will say that I am in Bombay. The date today is the 9th of August 2020. So that could be something. If I'm talking about road finding difficulties, so not being able to get to a familiar place, not recognizing the road, then there can be a sequencing activity which they are trained in. So each one of these functions will have a different intervention. Okay, so I hope that was useful. All right, Bijal Dalal is asking what develops in hierarchy, primary reflexes or sensory pathways? How can it affect the learning process?
So hierarchy was considered traditionally. It's no more considered, as the hierarchy model is completely out of this thing now. So what happens is, now the new model which is accepted worldwide is the non-hierarchical model. So it's normally driven by multi-sensory inputs, like the response coming from the patient depending on the demands which are placed on it. So for example, if I ask you to walk on a normal surface, you will just walk and come back. But if I tell you to walk on a single rope, what will happen is the body will automatically react. With whether I tell you or no, you will automatically react. You will put your hands out, you will look down, you will kind of use your proprioceptive system. So that's driven by multisensory inputs. So the learning normally takes place depending on the demands what you place on the person's body. So an assessment is important. So depending on your assessment, you place the demands on the person's body, less or more. If the person is good, your assessment wise you feel his predicted outcome is good, then you place some demands which will kind of activate more multisensory inputs. If the person is very dependent, very weak, then you place something which is very less demand on their body. This is how you make them learn.
Okay, so thank you. I think we have.
I'm not sure whether it's clear for the person who asked the question. He
I
understood
think
what
that
was.
was. Yeah, I think that was actually very clear. Let's see. So, Bijal, was that clear for you? And I'm just very quickly going to get some feedback. So I'm going to launch a poll for that while you have the rest of your questions coming in. Um, Also, so Dr. Gaurish, can you please type in your contact information? It'll be very helpful. And most welcome, everybody. Thank you so much for attending on Sunday morning. And as always, I think the discussion and the question answer is very helpful for, I think, for the presenters.
Thank you for everyone to be there. Yes. Thank you, Shraddha, for inviting me for
No,
this.
thank you so much for doing this. I've been wanting to do this for such a long time. I think the lockdown and this webinar format has made it so much easier for us to do it.
Thank you.
So yes, I think all in all, it looks like physiotherapists and psychologists both had quite a bit to gain from it. So great. All right. Okay, so if we can just get quickly some more answers, please, from the poll, it will be very useful. Yes, the link will be, I mean, I will be uploading it to YouTube hopefully by tomorrow evening itself. And I will share the link with Dr. Kenkre and you all can access it on the YouTube account. I will share the sort of the soft copy with you. All right, so thank you very much. Yes.
Brain function in childhood.
They share information related to how brain function in child with special needs. Okay. Okay, so I think the question is, how does the brain function in children with special needs? All right, so the first thing, Bijal, this is a developmental brain disorder that you're talking about. And just so that it's clear, everything that we've talked about is an acquired brain injury. What that means is you're asking about children who have been born with brain injuries or brain deficits, and we're talking about any sort of an injury that has taken place after the first day of birth. How the brain functions for children with special needs is going to depend on the needs that you're talking about. So if it's learning deficits, is it only a dyscalculia or a dyslexia, or is it a combination of all three learning deficits? Are you talking about children who have cerebral palsy and they could have more motor deficits as well? But a very short, sort of simple, I think very oversimplified answer would be that yes, the sort of brain networks, the functional loops in the brain for people and children who are born with deficits, now more and more it's getting identified that the loops are very differently organized than they are for individuals who aren't born with deficits. Dr. Kenkre, would you want to add to that?
I agree with what you said. Absolutely. So it depends if she is asking about the mental this
Yeah.
thing. And there are these IQ tests which are done in these patients. We can actually after the child is around 4 to 5 years, there are these IQ tests. I think which you people must be doing. So that also
Yes,
plays a role.
absolutely.
Finding out how well he will do cognitively.
Right. Yeah. There's a question specifically for you. In process of making a plan. Oh, it's sent to me privately. Okay. Um, in the process of making a plan or decision, could you explain how emotion affects the process and which part in the figure you explained before? Um, is that clear, the question?
It is for me.
It's for you. Yeah, it says for Dr. Gaurish, in
Uh,
process of making a plan. Actually, it's sent by Henny Gerda. Could you please reframe the question and could you send it to everyone? It's sent privately to me. I'll just repeat it for Dr. Gaurish. In process of making a plan or decision, could you explain how emotion affects the process and which part in the figure you explained before?
No, so emotion. So the figure which I explained before was more about how the sensory information is processed in your output to a motor function. So emotion would come more into a cognitive sense. I was trying to explain more about the sensory pathways. It is more about physical function rather than emotional or cognitive function in that figure. But yeah, body schema is something. So if you ask about that, then there is some important training which happens at the body schema level. So body schema is something which is like if you see before we used to get those negatives in the photographs. So you have to kind of do increase the pixels to have a proper photograph. So body schema is something which is built up by repetitions with practice and with learning. Emotion doesn't play a role. Emotion is one of the resources for developing body schema, but body schema would be one of the parts what I think must be the question in that figure, because that was something which was new.
Right. Yes. All right. I think the last one that we have is, do brain infections, even after being treated, cause long-term impairment? So once again, Fatima, the answer comes down to the severity of the actual injury. So I'm just going to explain the concept a little bit. So the injury is almost sort of looked at as the consequence of the original pathology from which this happened. So the pathology is the brain infection in your question, and the functional impairment would be what we see and what we view as the injury. And depending on the severity of it, so there are different parameters, like I mentioned. So, what was the duration of the post traumatic amnesia? Or what was the duration of possibly if there was a minimally conscious state? All of these predict and tell us the severity, the classification. And if it was a severe brain injury or a profound brain injury, then yes, there will be long-term impairment that continues to remain. Um, Dr. Gaurish, would you want to please add to that as well?
So, yeah, so we normally work on what are the functional impairments. Infection it was like if the infection was completely treated by medication, and if it has completely resolved and it was just compressing on the brain and it has completely resolved, then you can get over complete function.
All right, so I think that was the last of it. All in all, a very, very useful session, and this will soon be uploaded onto YouTube where you can access it. Thank you very much for joining us.